Hi everyone, and welcome to this START seminar series where Dr. Bryan Saunders is going to discuss methodological considerations for dealing with placebo-nocebo in sport and exercise studies. Bryan, thank you very, very much for accepting this invitation. Bryan is a colleague here in the University of Sao Paulo and also a good friend. This is a conversation that we've had many times, but I'm super keen to hear what you're going to say today and how you're going to frame this. I think it's such an interesting topic. For those who don't know Bryan, his main area of research interest is evaluating ergogenic supplements and how they may influence high intensity or high performance in elite sports. But within that broad interest, I know it's fair to say that two of the approaches that you take on that are looking at different factors that might impact individual response to supplementation, and as a branch of that, how placebo might influence individuals' response to supplementation. But he has a fairly broad range of work going on in this general area, so I won't talk that at all. But anyway, let's get going. Guys, any questions at all? If you would like to put them in the chat throughout the talk, we're going to have some time for questions towards the end. But feel free to put them in the chat whenever suits. Bryan, I'll pass straight on over to you then. Thank you.
Perfect, mate. Thank you very much. I can hear some echoing, but let's see if that stops.
I think that's me.
No worries. Anyway, that always seems to happen at some point. So let's see how we go. Yeah, so thanks for the introduction, Emma. Thanks for the invitation. I'm also interested to see how today's talk goes because, you know, I've been trying to get all my thoughts on this topic together over the last few weeks, months, etc. Since you invited me. Let me just get rid of this here. So as Emma mentioned, I'm going to talk a little bit about placebo and nocebo in sport and exercise studies, and trying to, you know, in the context. Sorry. What? In the context of kind of STORK and their area and aims, I try to bring with it sort of methodological considerations on this aspect. So a couple of disclaimers that I wanted to start with today while thinking this, you know, over the entirety of the talk, I'm not providing, you know, specific solutions or guidelines on how to control or measure. These are more sort of my own ramblings and considerations and thoughts. And likewise, I'm more than happy to hear sort of what other people's thoughts on these same topics are, if they have different opinions, if they have different solutions, because it's certainly not a one-size-fits-all kind of thing or one direction. But hopefully there'll be something in here that certainly people can take away, whether it be, you know, those people who are doing research or interpreting research for practice. As Emma kind of mentioned, my main specific focus over the last, I suppose, 10 years has been investigating the effects of sports supplements on performance. Kind of disclaimer, I would say I'm not an expert in placebo. You might think, well, why on earth has Emma invited Bryan to do this talk then? Well, you know, it's kind of who you know sometimes, isn't it? But you know, I think our research group is certainly entering into this area. We've got a lot of interest in the area of placebo and nocebo, specifically related to sports supplements. So a lot of sort of the examples I'll talk about today will be in the area of sports supplements. But you know, bear in mind, I guess this is where I say that you know, standing on the shoulders of giants and all that kind of stuff. There's certainly a number of big names out there who have really planted the seed of placebo research over the last, but in sport and exercise, probably over the last sort of 15 or more years. And one of those, for anybody who has an interest in placebo and nocebo, or has read in the area of sports nutrition and sport and exercise, they will know this gentleman over here, which is who is Professor Chris Beebe. So he's one of the probably leading researchers in the area, and he's done some fantastic work. And I always like to start with probably his and the first study in sport nutrition, kind of that highlighted placebo effects in the area. So just to detail the study, published about 16 years ago now. So they recruited trained cyclists to perform a 10-kilometer cycling time trial on various occasions. So after familiarization to the protocol, they performed a control session. So that control session, participants just turn up and perform the 10-kilometer cycling time trial. And that's kind of, you would consider the individual's baseline. So that's, a point of reference, and now any intervention, any change can be measured against this control. And so the individuals, or the cyclists, were informed that they would be returning on 3 more occasions, and in a randomized and double-blind manner, they were informed they would receive on one occasion placebo, one occasion a moderate dose of caffeine, and on another occasion a high dose of caffeine prior to the 10-kilometer cycling time trial. Interesting enough, looks like a normal study design. And so at the end of the study, obviously when the researchers wanted to look at changing performance according to the different scenarios, what they showed is that compared to control, the placebo actually slightly worsened performance. So 1.4% decrease in performance with placebo compared to control. The caffeine, or the moderate dose of caffeine, went the other way, so improved exercise performance compared to control. 1.3% increase, and an even greater increase with the high dose of caffeine. So you can see kind of here, we're seeing a kind of dose response effect of the different caffeine doses. You might be saying, well, I thought we were going to be talking about placebo, and what's the placebo stuff going on here? Well, the most interesting fact about this whole study is that on no occasion in this section was caffeine provided. Only placebo was given in this study. And essentially categorizing the individuals into the placebo, moderate and high dose was according to what the individuals believed that they had received. Okay? And so essentially believing that they received a moderate dose and a high dose seemed to have, again, a dose response effect on performance, but a performance improving and a potentially performance worsening effect, or a nocebo effect, which we'll get onto, when individuals believed that they had ingested a placebo. So these were the first data, I believe, in the kind of sport and exercise literature that showed that expectation, or believing that you'd received an ergogenic supplement, a positive supplement that would improve your performance, could actually improve your performance, even though you hadn't received anything. And there's several other, good studies out there to date confirming these data. But let's take a little step back then and think about what is a placebo and what is the placebo effect? How is it used in research? Why do we need it, etc.? Okay, so I think on the most simplest and basic level, really, most people would probably call a placebo, it's a physiologically inert substance. It could be a pill or intervention. It doesn't have to be a pill just because I work with sports supplements. It could be any kind of inert intervention. So essentially, it's something that in itself does not or should not have any direct effect. Okay? However, a placebo effect is something different. So a placebo effect, and again, probably the most simplest or most common definition that people will have heard of the placebo effect is that it's a beneficial effect arising from the belief that one has received a positive intervention. Okay? And again, a lot of people will say, oh, it's from the Latin, I shall please, and things like that. However, kind of delving into this literature, I think there's definitely some updates, there's definitely some hot debate about terminology, and I think terminology regarding these all these kinds of terms are important. And so I wanted to just hone in and focus in on that prior to moving forward, because we use a placebo in research generally as a comparator. So we provide on one occasion, for example, caffeine, and on another occasion placebo, and that allows us to compare the caffeine to the placebo. The individuals don't know what is going on, what necessarily they're ingesting on the day. But what people generally seem to think is that, so the placebo will not have any effect, okay? But I think that in itself is wrong. We already, in this kind of placebo control condition, we are expecting a kind of effect, okay? But that's almost a normal variation that we're expecting. So the purpose of placebos, and I really like this definition from Charlotte Blees, is that placebos in randomized controlled trials ought to be conceived as methodological tools, since their function is to kind of duplicate the noise associated with clinical trials, including spontaneous remission, regression to the mean, Hawthorne effects, and placebo effects. So obviously this definition is, I think, a bit more aimed towards the clinical setting, but I think it's pretty apt for our normal trials in sport and exercise as well. So when we provide individuals with a placebo, we're almost expecting a certain variation in that placebo group, or we're expecting, the variation or the change in the active intervention group to be bigger if it actually has an effect. So it's our comparator, but we're still going to see some noise within the placebo group, within the placebo arm of a trial. And that's where it's important, I think, as well, to differentiate between what individuals term placebo or nocebo responses and placebo or nocebo effects. Okay, so the placebo response is all kind of changes that result after administration of an inactive treatment. No? So natural history, regression to the mean, natural variation, think biological noise, biological variability. Okay, it's, our measurements are never perfect. There's always going to be some sort of noise. But then an actual placebo effect is a change that's specifically attributed to the administration of this inert treatment. Okay, and so it's actually attributed to specific placebo or nocebo mechanisms. Okay, and so this has been shown in several mainly psychological and neurobiological studies, that there are actual mechanisms behind these placebo effects. So I think, again, terminology and definitions are quite important here. And so I quite like this placebo definition. I think I might have got the actual reference wrong. I think it's another paper within this special issue. But anyway, so a placebo effect is a neurobiological response resulting in improved performance. And so this stems from an inert treatment. Again, the treatment has to be inert, and that could be sham drugs, nutrients, equipment, or even just cues to improved performance, like verbal suggestions, explicit expectations, or implicit experience. And so obviously, this is the good one that we want to a certain extent. And nocebo would be kind of the bad twin brother, so almost identical is, again, a neurobiological response, an actual, mechanistic response resulting in worsened performance stemming from these inert treatments, and usually associated with cues to worsen performance, such as verbal suggestions, explicit expectations, or implicit experience. Okay, so just a few definitions to kick us off. But I'm going to focus a little bit more on placebo versus nocebo, but I think, a lot can be inverted to the other way. And I think it was really nicely summarized by Phil Hurst, another fantastic researcher in the area. where they looked at all studies up to 2019, looking at the placebo and nocebo effects on sports performance of nutritional aids or mechanical aids. Okay, so it doesn't have to be supplement, obviously. It doesn't have to be nutrition. It can actually be mechanical aids. And so in all these studies, the participants were deceptively led to believe that they were receiving sodium bicarbonate, caffeine, erythropoietin, anabolic steroids, or even, again, relating to mechanical aids, you know, kinesiology tape, a magnetic wristband, a good tennis racket, etc., that could improve their exercise performance. And across all these studies, so we see an overall moderate or small to moderate improvement in exercise performance. Now, what I find quite interesting is across these studies, when individuals were led to believe that they were taking supplements that were similar to illegal performance enhancing drugs, you see the greatest effects. So again, something to do with expectation there, leading to greater gains. But I think the overall that we can take from this is that believing that you're taking something that works actually seems to work. So expectation is a huge factor, it seems, contributing towards exercise performance. Now, again, to bring this into context, we can see here sort of in one study with sodium bicarbonate, an effect size of 0.18, with caffeine 0.4, the average was about 0.35. If we put that into context with the ergogenic supplements that actually kind of, if we say they work, you know, the IOC consensus statement suggests that there are only 5 supplements that have good to strong evidence that it can improve performance. Those are beta-alanine, nitrate, sodium bicarbonate, creatine, and caffeine. Well, if we put that into context, we can see that the effect sizes associated with meta-analyses looking at the overall effects of these supplements, it seems to be the same size as placebo effects, as deceptively believing that you're taking the supplement. So again, I think it's quite fascinating to see how much expectation that you're receiving something positive can actually influence your exercise performance. Now, importantly, I think here we need to think about how these data were collected. What are the comparisons made here? And across all these studies, the comparators were the active ingredient, so the beta-alanine, the caffeine, or the bicarbonate, compared to the placebo. Okay. And as most people will know, these performed via double-blind supplementation studies. So again, you know, you provide on one day the placebo, on one day the active ingredient, or if it's a crossover, if it's a parallel group design, one group receives the good stuff, one group receives the placebo. But neither the volunteers know what they're receiving, nor do the investigators know what they're receiving. And so obviously what we want is that the supplements on both occasions are identical. So if the active ingredient looks like this, then you want the placebo to look like this. If the active ingredient looks like this, you want the placebo to look like this. Okay, so really important that we're controlling these well so that we're not modifying expectations. So individuals don't know what they're receiving. Now, obviously, this is great. This is important because the reason we do this is because technically we want to isolate the physiological effects of the intervention. So supposedly by doing this, making this comparison between active ingredient and placebo, we are isolating this physiological effect of the intervention. But in my opinion, and I go back and forth, and again, like I'm happy to hear other people's opinions on this. Like I keep on going back and forth about how for want of a better word, how good double-blind studies really are. Because when we think about the real-world effect or the overall effect of an intervention, we don't just have the physiological effects. We have the psychological effects and the physiological effects. We have that expectation alongside the real physiological effects. So when we perform these comparisons of active versus placebo, it doesn't allow us to measure the overall total effect of an intervention. And so this was something, so just to kind of visualize how that would look. When we think about an individual's control session, when they're not given any kind of intervention, this would be their normal performance. However, as we've seen, expectation can increase performance. So there might be a placebo effect associated with receiving a placebo. And likewise, when you're actually providing the active ingredient, what we'll probably see is those placebo effects summed alongside the active ingredient. And so what we wanted to do is we wanted to look at the literature and find how much placebo effects contribute to the overall effects of a supplement. And so how did we do this? Well, we performed a systematic review of the literature looking for caffeine, and this is actually meant to say extracellular buffer studies. So not only sodium bicarbonate, but also sodium citrate studies. Okay, so some of my students and alongside some colleagues, we took only studies that had an intervention arm. So that would have been, a caffeine arm, a placebo arm, but also a non-placebo control arm. Okay, and again, so this allowed us to quantify the placebo effect associated with these supplements, the total effect associated with, the intervention, so the intervention compared to the non-placebo control, and how much of that was due to supposed placebo effects. So within the literature, we only identified 35 studies. So 10 studies with caffeine had 3 different arms out of over 200. So more than sort of 190 studies only had the intervention compared to the placebo comparison. While the extracellular buffers, we identified 25 of well over 150, and that's probably well over 200 as well. So very few studies actually employ a non-placebo control arm. And we found a total of 55 outcomes. So when comparing the intervention, so the active ingredient, to the non-placebo control, we showed an overall small effect ranging from small to moderate. Okay, so a beneficial effect overall. Comparing the placebo to the non-placebo control, so receiving a placebo or receiving nothing, there was a very small but real placebo effect. So again, a positive outcome in general when receiving a placebo compared to receiving nothing. So again, expectation seems to have an effect on performance, and that's generally in the positive direction. Now, when we kind of compare the active ingredient to the placebo, that effect size drops. It's still a small and significant improvement, but the size of that effect drops. But again, I think that's interesting because when we take on board the size of the effects of a lot of these ergogenic supplements, they're already very small. So when we're making the comparisons to only a placebo, we're only seeing part of the picture. We're showing a very small effect, but actually it's a little bit bigger because you have the psychological, the placebo effects associated with the intake of these supplements. And perhaps to kind of visualize it a little bit better, when we look at the percentage or the contribution of placebo effects to the overall effect of these supplements, what we see is that between 25, but up to as much as 60%, almost 60% of the overall effect with these supplements comes from placebo effects. And so again, I keep on going back and forth, but I'm wondering, are double-blind, placebo-controlled studies appropriate for measuring what we want to measure, which is whether these supplements will work in the real world? We're not necessarily replicating a real-world scenario. We're kind of confusing individuals and making them not believe what they're taking, but in the real world, people know what they're taking. An important factor to consider here as well from our analysis is that we couldn't separate studies according to expectation. Okay, so these studies generally don't report what people believe they had ingested. So here, this is just an overall average. And so likely within each individual study, there'll have been some individuals when they took placebo, they will have maybe thought they were taking caffeine. When they were taking caffeine, they were maybe thought they were on placebo, and vice versa. Maybe they thought they were taking caffeine and they were taking caffeine. So we don't know how much that might influence performance as well. When you ingest a supplement in these double-blind studies, it's impossible not to have expectation. And generally that expectation will be positive, neutral, or more negative. And something associated with that, I think, is the side effects associated with some of these supplements. So for those of you who know, a common acute side effect with beta-alanine is a kind of paresthesia, a pins and needles sensation on the surface of the skin. The side effect with bicarbonate is, unfortunately, diarrhea, stomach upset, GI discomfort. With caffeine, I think it was probably the most well-known. People, you might get an accelerated heart rate. You might, feel more alert, feel better. And so when people are taking supplements in these studies, they will have expectation regardless of our blinding. And that might be because, I feel something, so I think I'm on caffeine. But that might also be, I don't feel anything, so I think I'm on placebo. And this happens in both scenarios, in both when they receive caffeine and when they receive placebo. It's incredible how many times when people receive a placebo, they have side effects that are similar to those elicited with caffeine. So we wanted to know or determine how much these kinds of expectations might influence exercise performance. So we performed a study with trained cyclists who performed a 16-kilometer cycling time trial, and they received either a non-placebo control, so no intervention, nothing, and on the other two occasions, in a double-blinded manner, either 6 milligrams per kilo of body mass of caffeine plus or placebo. So in general, caffeine improved exercise performance compared to both placebo and caffeine. It's probably an expected outcome. But like I said, we wanted to know what individuals were thinking, what they believed they had ingested, what they were expecting on the day. And so we asked people to identify what they believed they had ingested. So we kind of put them into categories that if they said they thought they were taking placebo on said day, that would be kind of a negative, because obviously, they could have been taking the good stuff. We put caffeine in the positive side of things because, well, if they think they're taking caffeine, they know or they believe they're taking the good stuff. And obviously don't know is more neutral. They just have no real idea about what's going on. So when we separated individual performance in caffeine and in placebo according to what individuals believed they'd ingested. So if we look at the overall effect of caffeine compared to placebo, was a 4% improvement in performance. But when individuals took caffeine and they believed that they'd taken caffeine, that jumps to 6.5% improvement. So greatest improvements were seen in those individuals believing they'd taken caffeine and they had taken caffeine. When individuals had taken placebo and thought they'd taken caffeine, there's that famous placebo effect, a similar performance improvement to the overall effect of caffeine. And when individuals have taken placebo and thought it was placebo, there's that potential nocebo effect coming into play here. So again, even with taking actual supplements that have a physiological effect, we can see that perhaps these can be, these improvements could potentially be greater if you actually believe that you're taking the supplement. And so here again, just to kind of visualize a little bit better, I think, yes, placebo effects are associated with the ingestion of a placebo, but those can go up or down depending on what the individual is or believes that they've ingested. So expectation seems to have a role in whether that's a positive, a placebo effect, or actually a nocebo effect. And likewise, when you're taking the good stuff, you know, your placebo effects might be greater if you believe you're taking the good stuff, and potentially, although we didn't specifically show it in our study, maybe this might be reduced if you you believe you're actually taking the placebo. So potentially a really important thing to measure in our double-blind studies. But the question is when? When should we measure this? Because actually the data I just showed you there was post-exercise, when they what they believe they'd taken when we asked them after exercise. But we also asked what they believe they'd taken immediately pre-exercise, or 1 hour after taking the caffeine or the placebo. So you can see here that caffeine, placebo, various individuals believe that they'd taken the good stuff or they hadn't. You know, 17 individuals on placebo prior to exercise believed they'd taken caffeine. But after exercise, after performing the exercise, a lot of individuals changed their mind. And actually, more people incorrectly changed their mind from pre to post exercise than correctly changed their minds. Okay? And so the graphic I just showed you, where the greatest improvements were in the individuals who correctly believed that they'd taken caffeine, well, actually, when we look at pre-exercise, the greatest improvements were seen in the individuals who incorrectly believed that they were taking placebo but were taking caffeine. So it's really difficult to quantify exactly how much expectation really does contribute to performance, and also when to measure this expectation. You know, I think it is important that we should measure it, but when? Should we do it pre-exercise like we did? Should we do it post-exercise? Should we measure it immediately post-exercise, or just as people are finishing, just as people are starting? Should we measure it at various moments throughout? You know, we're starting to get to the point where we're just getting so much data, and it's almost looking like a bloody solitaire screen. And we're going to have so much data that it's going to be impossible to analyze. You know, my 2 cents on this is that when we looked at the pre-exercise questionnaire and asking them, you know, what do you believe that you've taken? A lot of the individuals stated sort of the reason that, you know, for their choices were due to side effects. So, you know, whether they were on caffeine or on placebo at the time, you know, they identified that they thought they were on caffeine, usually because of associated side effects. Post-exercise was kind of a combination of the two. There were side effects, but also, you know, I thought maybe I was on caffeine, but then I started the exercise and I wasn't feeling that great, or I thought I was on placebo, but then I started feeling good during the exercise, so I think I was on the caffeine. So for me, I think that post-exercise supplement identification might be most accurate to measure expectation, because, you know, they've made a conscious decision. It might have been late on in exercise, but you would assume it's more likely to be early in exercise. No, actually, I think I'm on the good stuff. No, actually, I think I'm on placebo. And so that, I think, represents better what they believe that they were ingesting throughout the entire exercise protocol, and better reflects their true expectation and likely represents how they were feeling during the exercise. I'm happy to hear opinions on if people disagree with whether or not we should even measure expectation, when we should measure expectation. Again, I'm not here to say what's right or wrong. I'm here to sort of show what we've done and kind of what we feel that might be best. There's also other, suggestions that we should also ask individuals about the confidence in their choice. It's something that we didn't do, but something potentially interesting to ask as well. Okay, you believe you're taking caffeine, but how confident are you in your choice? Again, is this too much? Sometimes too much data can be, an issue, can be too much. So again, I'd like to hear your thoughts. I don't think I've settled entirely on this, and currently we're not employing confidence in choices at the moment. So, kind of summarizing some of the issues that I've mentioned, I think, particularly with double-blind, randomized controlled studies. So, when we blind individuals to, a treatment or a placebo condition, essentially the assigned odds is initially 50%, but that can obviously change, and expectations will change throughout, likely due to side effects, non-side effects, how they feel during the exercise, and that may or may not be associated with the actual intervention or not. And obviously we can actually manipulate expectations relating to the treatment. So, we might insinuate that people have a greater chance of being in the good group, the active intervention group, than not. And that can actually change your expectation as well, because you're thinking, oh, I've got more chance, so I think I might be on the good stuff. So how do we, go about controlling this in our studies? What should we be doing? I think another thing worth bearing in mind is that there are placebos absolutely everywhere in studies. When we perform a study, a randomized controlled double-blind study, lots of different things can influence expectation. The sex of the individual in the room, how many individuals there are in the room, the atmosphere of the room, whether or not they're in a good mood, in a bad mood, the type of intervention that you're performing, whether it be the placebo or the intervention, color, senses, touch, taste, all these kinds of things. How you deliver the information has a potential effect on your participant, which can potentially influence the outcomes in your study. And I think this is a fantastic article, and anybody who's interested in this area, I suggest you go away and read this article, because it's really, really interesting, in my opinion. So what do? Should we just stop? We can't really control studies. We don't know, we can't control placebo effects. We don't know how to measure expectation. There's so many different placebo effects that can intervene, can influence, can affect. Should we just stop and cut our losses? Obviously, the answer is going to be no. But I'm going to put up this quote here, that we shouldn't let perfect be the enemy of the good. And I don't know where this quotation originally came from, but she says it to me so often in our discussions that I'm going to attribute this reference to Ema herself. But I think in this case, it's great. Like, no study is perfect, but we just have to think about, the best ways we can control, what we should control, what we don't need to control in each of our individual studies. I think we just need to start thinking about it a little bit more. And in terms of my area anyway, I think the effects of supplements on exercise performance, I'm starting to wonder, are balanced placebo designs the answer? Again, that's an open question. If somebody wants to come out with an opinion at the end, I'm happy. I'm hoping to leave a little bit of time for discussion. And so just to sort of detail what is a balanced placebo design for those of you who don't know, well, it's a design in which we have 4 different, not interventions, but 4 different arms that the individual, essentially all individuals, will undergo if possible, if possible, in a crossover design. So sample A here, or arm A, is when you tell the individual that they're receiving the active drug, and they're actually receiving the active drug. And what does this do? Well, this mimics the real world. There's 100% theoretically expectation, because you're telling them they're receiving the good stuff, and they are receiving the good stuff. And this is the real world, in my opinion. Nobody, unless you're on some unnamed IOC associated doping regime, most people know what they're taking. Your coach should be telling you, here, this is caffeine. So this mimics the real world. In arm B, we're telling the individual that they're getting the drug or the active ingredient, but they're actually receiving placebo. And this accurately quantifies the placebo effect, because again, we've got 100% expectation, but they're not actually receiving the good stuff. So this is how we quantify accurately the placebo effect. In arm C, we're telling the individual that they're not receiving, or they're actually receiving that they're receiving the placebo, but in actual fact, they're receiving the good stuff. So here, essentially, we're reducing expectation to 0, but we're quantifying the actual physiological, the pharmacological effect of the treatment. And then in number D, no treatment and no treatment. And that quantifies control. There's no expectation. This should be theoretically the normal baseline. And so there are several studies out there that are investigating, or that use this study design. We're about to start a study in our own lab using this kind of design. And I'm starting to wonder, maybe this is actually the best kind of design for us in terms of supplement studies and their effects on exercise performance. I'll just quickly gloss over this because I'm rambling on a little bit, but there are other potential experimental designs where you suggest to individuals that they're going to get on one occasion a positive, one occasion a placebo, on one occasion a negative. You even tell them on the day you're getting the good stuff, neutral, the bad stuff, but actually on every occasion they only receive the good stuff. And so in that kind of way, you can also manipulate expectations. So thinking about a little bit, where do we go from here? So I think we should keep going, but strive to improve our study designs wherever we can. And I think that starts with asking the right questions. And one of those questions, I think, is related to placebo effects and placebo within our own studies. Do we want to measure placebo effects? Do we want to know how much the placebo is influencing the total outcome? How much of the total outcome is due to this? Or do we simply want to control for them? There's no issue with that. I'm more on the left side of this equation because I'm interested in actually knowing about placebo effects and their mechanisms. But it's a question that we need to think about before we choose our study design. That, I think, will lead us towards a specific study design. And then, of course, we need to acknowledge limitations of whatever design we do choose. Okay, so in my opinion, that's kind of where we go. Am I right? I don't know. I'm more than happy to hear your opinions. I think it's fascinating to think about, and I've been going round in circles and circles the last few weeks thinking about this. So just a final few tips and pointers and things to think about, I think, when putting together double-blind placebo-controlled studies. Because we need to ensure that what we are measuring is not just noise. And that goes for both the intervention and the placebo. Okay, and I think there's a few things that we can do to ensure that. So we need to standardize our procedures, perform tests at the same time of day, ensure that nutrition is similar or identical from one day to the next, that one day they're not coming in after having done a marathon the day before, and the next day they're coming in fresh. Even the information that you relay to the individuals, again, that's important. That can generate different expectations. So I think we need to ensure that we standardize procedures as best as possible. Control your environment. I don't mean just temperature and humidity, but the researchers who are there, try to standardize that as much as possible. If there's always 3 men in the room, or if there's 3 men in the room in the first test, make sure it's the same 3 men for the next few tests. Try to keep a similar atmosphere, if it's difficult sometimes, but if you've had a bad day, try not to let that affect you, because if you're in a bad mood one day but in a good mood the other day, that can influence outcomes. There's data to show that. We need to use reliable exercise protocols, have individuals perform familiarizations to the protocols. Ideally, in an ideal world, the individuals would be habituated to the exercise protocols. But if we know the typical error of the test, well, then we can know if individuals are performing within that typical error or outside of that typical error. A 5% improvement, and you say, oh, it's a placebo effect or an effect of the intervention. But if the typical error of the test is 10%, well, then you don't really know if there was a performance improvement or not. Think about the types of participants. In an ideal world, we use more trained individuals because their performance might be more reliable, but we don't live in an ideal world, and untrained individuals sometimes more accessible. We need appropriate sample sizes to again determine whether or not these changes are not just noise. Think about the intervention and active treatment. We need to make sure they're identical in almost every way, but again, I think we should measure expectation, what participants thought was ingested, their subjective feelings. We should measure side effects. And something I'm not going to get into, obviously, but we need appropriate statistics as well to ensure that that it isn't just noise, but these are real changes in performance. As I mentioned earlier, I think we need to ensure that we include actual true non-placebo controls where no intervention is provided, so that we can calculate the biological noise, the biological variability, and compare the placebo changes and the intervention changes to this. For those of you interested in placebo effects, I think we need mechanistic studies measuring physiological responses, neurological responses, neurotransmitters, brain activity. And this can complement, this can corroborate any performance changes. Because if there are no mechanistic changes, well, maybe that placebo response is just noise. Again, and that can help to, determine whether or not it's a placebo response or a placebo effect. And again, I'm starting to think are balanced placebo studies maybe the best way to go about this. I don't know. I'm happy to be told they're not, and happy to hear other thoughts and opinions. A quick shout out to this fantastic special issue. A lot of my thoughts and ramblings were taken from here as well. So European Journal of Sports Science, some really great papers in this special issue. And that's it from me. I hope that there was something fruitful in there for anybody. I'm happy to people get in contact, and I'm also happy to potentially discuss anything now if anybody has any questions or any opinions. Cheers.
Brilliant. Thank you so much, Brian. So much in there. So many different aspects. I think that this can be approached from. It's hard to know where to start. Guys, anyone who does have a question, please feel free to either put it in the chat and I can read it out, or if you prefer, simply unmute yourself and ask your own question. Whichever you feel more comfortable with is absolutely fine. I'm keeping an eye on the chat here. But ask questions coming in. Brian, I have a couple, that as always.
As always.
I think one of the question that you pitched on one of the last slides there, where you're basically, should we be controlling this or should we be investigating this? I can't remember how you phrased it, but I think that is a hugely relevant one. And I wonder, do you have any thoughts or feedback in terms of what factors different people should be considering? I assume it's hugely going to depend on your research question and say the population that you're targeting, ultimately what you want to get out of your research, the approach that you would take. But I just wondered if you had any kind of advice in terms of the things people should consider if they're having to make that decision.
Good question, Eva, and a difficult one to answer, I think. How do people go about actually doing this? I think my suggestion for using kind of non-placebo controls, I think should be the way for us to go to determine placebo effects, because essentially without that we're not measuring how much of a potential effect is due to placebo effect, if there is an actual placebo effect associated with your intervention. But we also know that, you know, potentially another arm to any study increases costs, increases time, increases needs for participants. And so I think there's certainly in some studies where you simply want to know what is the effect, the physiological effect of a supplement on X or Y, or, you know, you're not that interested in the placebo effects. I think potentially you could scrap that control arm, especially if it's, you know, it's impossible because of money, and so you have to think about where, you know, that's a potential way to go. If you are more interested in, we also would like to know placebo effects, how much are associated, how much of any response is associated with a placebo effect, then I think including a non-placebo control arm is essential. So I think that's one way to think about it. And also, again, mechanisms. I think sometimes we're all a bit guilty of maybe not measuring mechanisms enough to justify a performance improvement. And so I think measuring mechanisms alongside placebo changes, active ingredient changes can help to corroborate, to show. Because in my opinion, if you show a performance change but you don't show a mechanistic change, doesn't mean it didn't work. You might be measuring the wrong thing, of course. But I think it just helps to corroborate, oh yeah, so there was a performance change, and oh look, we also showed changes in physiology that really support these placebo changes. So I think those are a couple of rambling ways to think about it. But yeah, I think even in my own head, I really have to think about these things a little bit more, because you know, I keep on going back and forth about what's the best way to do these things.
Yeah, definitely. Just so much to consider. I suppose what I was thinking as you were talking there is ultimately it's all going to come back to the goal of your research. Like, obviously, if you're researching placebo, you have to consider all of that. If you're interested in the physiological response to a supplement, you probably want to just your normal placebo group is maybe enough. If you want the real world applications, maybe you don't need a placebo group at all. I suppose it's just really thinking about what your end goal is. Might be a thing, which is obviously not easy. I again, as always, I have loads of questions, but anyone else who wants to pop in, because I wreck Brian's head with these questions all the time.
Asking me questions I can't respond.
Hamilton, do you want me to, I'll try to read this out. Random question from Hamilton. How do you reckon strategies such as those employed in studies on hydration as effective in assessing physiological effect of a given intervention, considering the strategy itself does not mirror real-world application? You're probably saying this question yourself.
So how do you reckon strategies of those employed in studies on hydration as effective in assessing physiological effect of a given intervention? Okay, I'm trying to wrap my head around the wording here, Hamilton, but obviously, yeah, because a lot of the earliest studies on hydration and its importance for exercise performance are limited by the fact that, you know, initially people thought the only way to do a hydration or dehydration study is, you know, you either keep people hydrated by them drinking while, you know, losing sweat, or they don't drink while losing sweat. And so that in itself will have potential nocebo implications. You know, people will feel like crud. They know they're not drinking. They know they're in a rubbish trial. So that could potentially influence performance. But now there's several studies that try to maintain hydration or not by, you know, putting a nasal tube down into the stomach in which they can individuals can then be kept hydrated or not throughout the exercise, and they might drink only small amounts of water just to, you know, to not feel to essentially mimic as if they're drinking a little bit, but not to have that sensation of a dry mouth and all that kind of stuff. How do I feel about that? Well, I think Lewis's studies are really interesting in that I think they kind of show that some of his studies suggest that whether people know or don't know whether they're hydrated or not hydrated, there seems to be a negative effect of dehydration on performance. So I think previous literature could have been criticized for not being blinded, essentially people knowing that they were dehydrated or not. But I think some of Lewis's data suggests that actually, whether people know they're dehydrated or not, dehydration seems to have a similar impact on exercise performance. But I think maybe more work is needed. I think Lewis has only done a couple of studies on the matter. So I'd certainly like to see whether or not, you know, in larger groups, different groups of athletes, whether or not, you know, their expectation about being dehydrated or not has an effect. I don't know if I answered the question there really, but I was just rambling a little bit.
I think there's no clear-cut answers to any of these, but one thing I find really fascinating about those studies that Lewis did is about, like, where does the physiological effects of a strategy or thing, it kind of blends into the potentially psychological effects, because feelings like mouth dryness are, you could say it's a psychological thing, it's a feeling, but it's going to send a signal to the body to tell you that you need to drink or not, to give an indication. I think they really open questions about when a purely physiological effect kind of bleeds into more of a central, and then you lead into the whole central versus peripheral control of fatigue kind of discussions, and where I think they're really fascinating.
I think potentially get into, like, at some of these placebo conferences as well. There's a whole debate about terminology, and you know, should we even use the term placebo? Like, if there's a placebo effect, if it's an effect, well then it's not a placebo per se. And you know, there's a whole fantastic discussion, because you know, essentially what the literature suggests, or what the experts suggest, is that a placebo effect is an actual measurable real effect. Again, it's a placebo effect, not a placebo response. But once there's an effect, well, then is it really a placebo? And
Yeah.
you know, you go down a whole rabbit hole, and there were some fantastic debates about this, so that, you know, again, go far above my head, but it's something fascinating to think about anyway.
Yeah, I think that's very true, because ultimately, if we're investigating effects, we shouldn't really be so biased as to where they come from, because if there's still, obviously, we don't want to go down the role of snake oil salesman where we're promoting everything without any physiological mechanism. But if certain physiological mechanisms are likely to lead to a greater ergogenic effect because of their mechanisms, for example, we always dismiss somebody says to get an effect from beta-alanine acutely because we kind of know that doesn't align with mechanisms because they're not going to increase carnosine. However, they're feeling that paresthesia, it's having an effect.
Yeah.
Ultimately, goal achieved from the point of view of the athlete, at least.
Exactly.
It's an interesting discussion. But Bryan, conscious of people's time and of your time, and we try to stick to the hour. So I'm going to officially wrap this up and stop recording. And thank you very much. However, if you or anyone else wants to stay on and chat for a few minutes, that's more than welcome. But I'm going to officially wrap this up. Bryan, thank you so much. Such an interesting topic and so much to think about. Guys, just to let you know about a couple of things coming up. Our next Stork seminar is going to be by Dr. Anne Hegsteden, who is going to talk about the small n, small effect dilemma and what it means for researching in elite sports performance. And I think that's something that will be very relevant for a lot of us when we know our intervention is likely to have a small effect. However, we've got a small pool of participants to draw from. What to do. So Dr. Hegsteden has a lot of fantastic work in this area. So I think that'll be a really nice one. That's on March 23rd. And also, as many of you know, Stork are organising a summit. It's going to be an online event now, a 2-day event in June. And we are currently accepting session proposals. That is open until the 28th of February. So just 5 days left to submit there. But we're also open for abstracts, and registration will open soon. So just keep an eye on our website and follow us on Twitter. Join us if you're not already a member, and to keep in touch with all of these things. So again, Bryan, thank you very, very much. I'm going to stop recording here now.